Hi, everyone. Welcome to our Executive Leadership short course entitled An Equity Approach to Pandemic Preparedness and Response, Emerging Insights from COVID-19 Global Response Leaders. This is our second session of the course, offered jointly by Partners in Health and the University of Global Health Equity. I'm Amy DiMatteo, our Senior Manager for Project Operations for the Learning Collaborative at Partners in Health, and I'm going to give you a few course details as we start. Next slide, please. This course has 4 sessions in total. Each session starts at 10 a.m. Eastern or 1600, 4 p.m. Central African time. The sessions all last 1.5 hours with an optional question and answer session time after that. Next slide. Sorry. To receive certification for the course, please join us for all 4 webinar sessions. If you didn't see session 1 live, you can go back to the course website. We'll put a link in the chat in a moment. You can watch the recording. If you page down to the bottom of the session 1 page, you'll see the recording there. After watching each webinar, please complete each session's assessment survey. The survey gives us feedback on the session and it checks your understanding of the material in the course. The survey for session 2 will not be live until after this session today. We'll put the website link in the chat function in a moment. Please feel free to click that website link and scroll down to the box labeled Session 2. Click Learn More, and there you will find all the materials for this session, including today's case study that will be presented entitled Contact Tracing and Equity, the Role of Wraparound Support in Combating COVID-19 in Massachusetts. On the course website, you'll also find additional readings and the link to the assessment survey. During today's webinar, please submit any questions you have for us in the Q&A section on Zoom. You'll not be able to submit anything in the chat section to us. Again, please place any technical questions or any questions you'd like to ask the panelists related to the course material in the Q&A function. We'll also try to do some closed captioning at the bottom for some of the questions. The slides will be posted on the course website afterwards, and the video, again, will be posted on the course website afterwards. Thank you. I'll now turn it over to our course directors, Dr. Anatol Manzi and Dr. Phaedra Henley.
Thank you, Amy. So as you just said, I'm Anatol Manzi. I'm the Deputy Chief Medical Officer at Partners in Health and the co-director of this course. Welcome everyone to Partners in Health and the University of Global Health Equity. This is a second session, and if you are attending for the first time, welcome. We also want to say that you are not alone. So we have over 2,000 participants and from over 80 countries. Actually, in fact, yesterday, we got 2,400 participants who were online. So obviously they may not attend all of them, but eventually this is really a recognition of your presence. I wish we could also announce everyone's name, but we may spend months and months. So I prefer really showing a number of countries that are attending today. Next. And this is the second session I just mentioned, as I mentioned, and this obviously follows the one that was talking about COVID-19 and global health equity. This session was very interesting, and we want to give a short recap of the session, and I am here with my colleague, Dr. Phaedra Henley, who will be helping us to just give 1 minute a recap of the session. After that, we will see the case study presentation by our professors and the guest lecturers. We also have a panel discussion toward the end, and we will have a session with Q&A. After this course, we actually the panelists offered to have an office hours. So these office hours are optional to everyone. So if you want to join, please join for personal questions and any other interests you may have, especially connecting with our professors. I would like to invite my colleague, Dr. Phaedra Henley, to give a brief recap of the session that we covered on Tuesday.
Thanks so much, Manzi. Hi, everyone. Welcome back to everyone who was here on Tuesday, and welcome to all our new attendees. We're really excited for this session and to have you join us. So as Manzi mentioned, my name is Phaedra Henley, and I'm the Director of One Health at the University of Global Health Equity here in Rwanda. So I know last time we had a lot of questions about UGHE and about our programming. So stay tuned for more information coming through there, and I'll be here live answering some of your questions about the programming we have at UGHE, which includes future programming on pandemic preparedness and response. Last session, we talked about COVID-19 and health equity. We had Dr. Sheila Davis, Paul Farmer, Joya, Dr. Agnes, and Professor Abebe Bakale talk us through a case study as well as through a panel discussion. So we reviewed the early warning indicators of COVID-19 and global inequities that the pandemic was amplifying, including the legacies of past pandemics and the inequities. Overall, we saw that when people do not have the agency to follow public health guidelines, these guidelines will fail. The most marginalized and vulnerable will not be protected, and this will drive the continued spread of and devastation from the pandemic. We saw when community members are not central to the response, and when leadership is not accountable and compassionate to their communities, particularly those most vulnerable, the response will fail. Learners were presented with the basic principles for developing and sustaining an equitable and effective response to pandemics, such as the provision of necessities needed to follow public health guidelines, such as transportation feeds, housing, and food, but most importantly, a strengthened health system and public health care. We saw that without addressing health equity, we cannot effectively respond to or recover from COVID-19 or prepare for future epidemics. These lessons and principles will be reinforced in today's case study and panel discussion on contact tracing and equity in Massachusetts. So I'll turn it back to Manzi to continue the session.
Thanks, Phaedra. In fact, today we're going to talk about the case of Massachusetts, but with a global application. So if you are not from Massachusetts, don't worry. This actually is all about the global perspective. Well, I also want to say that someone from these trainings, from this course, emailed me yesterday and asked me, if I forgot everything, what would you advise I should really retain? Then I said, if you forget everything, then you should at least keep equity and leadership. So I hope that is really a good summary, at least from my end, in terms of recap. So next slide. So with this course, I want to introduce someone here who would be the discussant, and I want to invite her to obviously give us a recap on why do we do what we do, especially in this course, but also give a brief introduction of the faculty that we have. Before then, I want to really take a time to introduce my mentor, friend, and colleague, a leader, an activist, Dr. Joya Mukherjee. She's the Chief Medical Officer at Partners in Health, Associate Professor of Medicine at Brigham and Harvard Medical School. She's the Director of the Master of Medical Sciences in the Global Health Delivery Program at Harvard Medical School. This sounds very academic. This introduction sounds very academic. I'm going to introduce you, Joya the way I know her. There are some photos you see below. I did not take this. They're from different time, different locations. And if it was a trivia question, I would ask you, what do you see? I wish I could get an answer here. There's one thing I see in all these photos. I can see Joya's right hand. And I came to realize that over the past 15 years that I worked with Joya, every time she is to stand for social justice and other important matters, she would always raise her right hand. She did not know that This is the first time I give her feedback. So today, we are going to witness her right hand. And today, I think it's time to hear Joya discussing this topic and raising the power of her right hand. Dr. Joya, if you can go ahead and recap why we do what we do, and also introduce the faculty for this course today. Welcome, Dr. Joya.
Oh, thank you, Mazi. I'm a bit overwhelmed. My right hand is a little bit in embarrassment here, but thank you very much. That was very, very kind. I think we all who work together, we know that the right hand of our work is really the patients and the people who are most affected, and that is the voice that's always coming in our ears, are the people who are the most vulnerable. Partners in Health, where I've had the privilege to work for more than 20 years, is a nonprofit social justice organization which is striving to make healthcare right for everyone, but really preferentially the most vulnerable, the most afflicted. So wherever we work, we are focusing on the people who have the least. Next slide. We work in 11 different countries throughout the world, including the United States, but Sierra Leone, Liberia, Haiti, Rwanda, Malawi, Lesotho, Peru, Mexico, Russia, and Kazakhstan. And in all of those places, whether they're wealthy countries like the United States or Russia, or less, more impoverished countries like Malawi, we are focusing on the vulnerable. And I think Phaedra gave such a great recap of our last session, which is why are we even doing this course? We're doing this course because we believe that we must fight COVID from a lens of dealing with health inequities and with the perspective of needing to achieve equity, because pandemics affect the poor disproportionately. It's true in every country around the world. It's true with every pandemic. So we really feel that there's no fighting COVID without fighting injustice and inequity. Next slide. So Paul Farmer, our founder and chief strategist, talks about this term expert mercy. And what he means by that is that mercy or kindness or righteousness comes in a contextually specific way. So if you're dehydrated, the mercy you need is IV fluids. If you have COVID and you need to quarantine, the mercy you need may be baby formula, so you don't have to go to the store. Maybe cash transfers because you've lost your job. And so expert mercy is tailoring our solidarity and our response toward the direct needs of the most vulnerable. And so we think that it can be anything from high-level medical care, a ventilator, to companionship and literally social support, someone to talk to, and everything in between. Next slide. We're really privileged that over the last few years, we, Partners in Health, with really great colleagues in the government of Rwanda and across the world, in fact, have started a university to teach this approach. And everyone here, certainly Emily, Manzi, and Phaedra are all also professors at the University of Global Health Equity, the physical campus. On the physical campus, Dr. Phaedra Henley leads the One Health piece of this. We had the Dean, Abebe Bekele, on our last call, and our Vice Chancellor and Chancellor, Paul Farmer and Agnes Binagwaho. But the point of UGHE is to say Rwanda's done great things. And in our last session, you will hear about Rwanda's really peerless response to COVID, which is really led from an equity agenda. And based on what we know from Rwanda and the successes in Rwanda and the principles of equity, this university is founded. So the partnership of PIH and now this teaching arm that we have is really what is bringing you this discussion today and this course. Next slide. So we are going to talk about contact tracing in the United States. And so those of you who are from the African continent or from Haiti will recognize right away contact tracing, because public health is a known entity in most places. But in the United States, it's really not. And so as Partners in Health was preparing with our colleagues around the world in Rwanda, Malawi, and elsewhere, how would we get ready for testing, for contact tracing, and for treatment as COVID spread across the world? One of our co-founders, Jim Kim, said, why aren't we talking about this in the United States? And we said, well, nobody really asked us. So he talked to Governor Charlie Baker, the governor of the state of Massachusetts, where Partners in Health is based. And Governor Baker said, it sounds logical, let's do it. Let's support the government, the public health department, and support communities and try to get this preventive approach right. Because in the US, what you see is a failure of prevention, a failure of public health, a failure of equity. And so we are one little group in a little state that's trying to fight back in many ways with lessons Emily has learned in Malawi, and Oscar learned at the Dominican-Haitian border, and John learned in Sierra Leone, and Monzi and Phaedra learned in Rwanda. So what we see is we're bringing these lessons to the state of Massachusetts to try to augment and improve the response in one little state of our large country. Next slide. So this is a fragmented slide. It's not meant for you to look deeply into the boxes, but here is part of our problem. So I want to give this especially for people who are tuning in from outside the United States. We have public financing of some pieces of insurance, not really of our system. So we have the federal government that pays for the elderly, predominantly veterans, and some small groups. The state and federal government that provides insurance for the poor, particularly women and children who are poor, but not all of them. And then the large majority of healthcare is delivered through privately financed insurance, often attached to employment. So as you see employment rates plummeting, this is at risk. Now, the other problem is that across these three sectors, there is no coordinated planning. So the federal government does not have an ability to be very strict with planning, as you will see later in the Rwanda case. What you also don't see, I just want to stay here for 1 second. What you also don't see here is any public health. All of this is about how treatment is funded, but public health exists in a separate sector, and it's run by the states. And so what we saw in the United States was an extreme focus on treatment and no focus on prevention. And so one of the reasons this has gotten so out of hand is there's very little public health. It's been gutted over many years, and it is not integrated with the treatment sector. So I just want to give you that highlight as we go to our discussants who've been, deeply embedded in this now for 6 months. Next slide. So the learning objectives of this session is to review what we consider to be effective contact tracing, particularly around this equity issue. Understand the role of public health leaders in equity and how this public health being left out versus being part of a federal planning is so complicated, and the fragmentation of public health. We want to discuss some of the preliminary lessons and successes and challenges that we've had in Massachusetts to understand the types of social support needed, and describe the clinical care for referral pathways. And we're going to have Dr. Emily Rowe and Dr. John Welsh discuss the case. They've been leaders in the efforts. Next slide. You can read their amazing credentials here, both at academic hospitals in the United States, as well as global health experts. Oscar Baez is a frontline care coordinator and has worked with vulnerable communities during this pandemic. And Dr. Shada Rouhani is going to give us some perspectives on being a frontline provider in the United States fragmented system. She is an emergency medicine doctor who also has set up the first emergency medicine residency program in Haiti, and has worked with many countries in Africa to set up critical care services. So we've got a great set of experts, faculty, panelists, and I would like to turn it over to them. Thank you all so much.
Thanks so much, Joya and Monzi and Phaedra and everyone. It's really a pleasure and an honor to talk with you all today and to kick us off in this case. So on behalf of everybody from the Massachusetts Community Tracing Collaborative, thanks for taking time with us today. A few important concepts that I think most of us here are probably familiar with, but we'll just spend a moment on them. First, kind of as Joya and really everyone so far has highlighted, the point of all of this work is to use equity as a foundation for everything that we do. And this is, I actually wrote this definition. I don't know if Joya or others would necessarily fully agree or add to it, so please do if you'd like to. But really this idea that that everyone should be able to live to their fullest capacity without any consideration for differences between social, economic, demographic, geographic, or any other sort of influence in that capacity to live fully and freely. And also, you know, that the idea of health itself is one that is must always incorporate the patient and the patient's perspective of what health is to them, and us as healthcare providers working with the patients to achieve that in the most equitable fashion. Of course, this is all based in the COVID response, which is, you know, our work in Massachusetts has a lot to do with contact tracing. And so briefly, as many of you know, contact tracing is just a very systematic way of identifying folks who have been exposed to or potentially exposed to a communicable disease. And really the goal of contact tracing is to break the chains of disease transmission. We do make a little differentiation between quarantine and isolation, and so you'll hear us using these two terms. They're not interchangeable necessarily. Quarantine is separating those who have been exposed to a potential communicable disease, and isolation is separating individuals who have in fact tested positive for that disease. We can go to the next slide. So those of you who know Partners in Health and know UGHE have heard this all before, but I think it's really important to continue to talk about the fundamentals of what the approach to this work is. And also, I think what's so important at the top there is prevention, treatment, and care, and that all of those are given equal attention, that we don't focus just on one over the other, and that all along treatment is tied to care. And you'll find in this discussion that we are tying very closely our activity of contact tracing to care. But the fundamentals of that care are these 5 things here: staff, stuff, space, systems, and social support. And really, we can't have a comprehensive approach, and we can't have success in that approach if you remove any one of these pieces. And really, that social support piece is what holds the rest of these up, I think. So this is kind of the way that we frame all of the work that we do at Partners in Health. Next slide. So Joya briefly mentioned kind of how our work in Massachusetts came to be, and that was Jim Kim and a few others asking, you know, why aren't we implementing this comprehensive public health response and really using contact tracing as a mechanism to care for folks? And then those of us who kind of sat down to bring that to fruition really generated this idea of tying care resource coordination and tying care using contact tracing through the care resource coordinators. So it's really important to note that the effort isn't to duplicate any services that already exist. The effort isn't to replace any, cadre of workers in the United States. The effort is to link our cases and their contacts through the resource coordinators back to the things that exist in their communities, the resources that exist in their communities, and also then to pay really close and special attention to resource gaps that we notice. And we'll get into this a little bit later on, but it's really fascinating to realize, based on geography and other factors, that in the United States, there is not health equity when it comes to providing these resources and connecting people back to those resources. It's really important here that we will accompany our patients through this journey, and in this context, it's COVID. So whether they're a case or a contact, we will accompany them through that journey and link them to the available social supports. And I think the other piece of that, it says here, available social supports. I think it's important also that when we identify gaps, we use our voice to advocate for filling those gaps and trying to find mechanisms to fill those gaps. We can go to the next slide. We've got an incredible group of care resource coordinators that work with the Community Tracing Collaborative Massachusetts. They speak 23 different languages. And we paid special attention and made real effort to recruit our resource coordinators from different geographic locations around Massachusetts, based on the experience of people sort of living there and working there, to make sure that we were really being representative of the people that we're serving, and also that we weren't really leaving any stone unturned in identifying resources. And the people that we've hired have come from many different backgrounds, but they've really banded together to do this work. I will also just say that one of the biggest value adds to this whole thing has been identifying and collating all of the resources that exist. And the fact that those now sort of exist in a single database is just sensational. Dr. Rowe is going to talk about that in a moment, and I'll turn it over to her. But I can't stress enough what an incredible group of folks that our care resources coordinators are. Emily?
Great. Thank you, John. My name's Emily Rowe. It's great to be here with my friends and colleagues talking about this important topic today, and to see so many people online from around the world. And I'm particularly honored to just get to represent the around 150 people at our peak we had working as care resource coordinators in Massachusetts. Just a very dedicated group of people to fight for equity during this pandemic. And John and I put together these slides to really try to show everyone what this looks like. How do we sort of take theory to practice, and how did we start this? And it was a sort of big effort to get things going quite quickly, to try to keep up with what was happening in Massachusetts. And so the CRC team structure, they sit embedded with the contact tracers and case investigators. Everybody's working on the phone, which is a sort of added challenge of the times that we're in. So the CRCs, as we call them, are led in teams, this geographic distribution across the state of Massachusetts, by resource navigators who are really supervising them and providing documentation around best practices, helping with difficult cases, and liaising with the local public health system that's within the Department of Public Health in Massachusetts. other things rose to the surface as key challenges, and we really drew on the deep expertise on our team of care resource coordinators as we identified these really important topics. So you can see there in the thematic working groups that these challenges really rose to the surface as really important things to address as we were supporting cases and contacts as they were at home in isolation and quarantine. You'll hear from Oscar later, who leads our thematic working group on immigration, trying to work so that we can position ourselves to best support people from immigrant communities. We have a violence thematic working group as we were uncovering a lot of issues of safety in the home for elderly, for disabled people, for women, for children. And being on the phone with vulnerable people, you know, doing epidemiologic investigation when what can be much more important in that moment is supporting somebody who's in an unsafe situation, and trying to equip a staff of 1,500, 1,700 people at our maximum to know what to do in that circumstance, what to say, who to call, what resource to provide and these are really complicated questions and scenarios that our staff end up in. So we have some deep experts working on our team on these tough questions. The benefits thematic working group really looks at access to care. And Joya showed you that complex slide of a very difficult to understand health system in America that unfortunately has a lot of aspects of a bit more of a marketplace than a social system, and often leaves out the most vulnerable. And it's something that we really struggle with in the US. And so the benefits working group looks at trying to connect people to primary care physicians and to be able to get tested for COVID when they need to. And then another group that's come from that work is supporting people at home that are struggling with mental illness during these tough times, as well as substance use. And then we also have some geographic task forces, and these really came about in communities that were really hard hit in the first surge in Massachusetts. So you can see there, Brockton is a place where there's a lot of immigrant communities, a ton of languages are spoken there, there's a lot of poverty, it's a really diverse community, and there was a lot of cases. And so the geographic task force brought together the care resource coordinators, people from the local board of health, people from the mayor's office to really identify what are the biggest challenges in this community and try to tackle them together. And so in this, you can kind of see that we're charged with supporting a statewide program, and that really comes to life on the ground locally in these local communities. And so we've been trying sort of different approaches to try to do that, and you'll get to hear more about that in the Q&A. So the next slide just gives you a little bit of sense of what are the care resource coordinators doing at work. And thanks, Hannah. So the first thing is, when people who have COVID in Massachusetts or are exposed to COVID, they get a phone call from the large contact tracing team. And there's a lot of things to do on that phone call, as you might imagine, around collection of symptoms, letting people know that they've been exposed, referring them to get tested. There's all the sort of epidemiologic check boxes that comes with contact tracing, but we know that that's not the entirety of contact tracing. And to really focus on the equity agenda, we also took the opportunity of that phone call to try to say, how can we quickly identify who needs additional support? And this is important for equity, and it's also important for the pandemic. These go hand in hand. There's literally no point to contact tracing if you can't support people to isolate and quarantine. So even from a pure numbers perspective, we have to figure out how to support people so that they can safely be at home and undergo the sort of isolation and quarantine procedures. So we added a brief home assessment during every phone call when we get a hold of people in Massachusetts that goes through that list of themes there you can see on the lower left part of the slide to try to identify vulnerable people at home. And then we trained the entire contact tracing staff to sort of prioritize. And there's lots of examples of these, of how urgent is this? Do we need to get to people today? Maybe they're running out of food later. Maybe Joya mentioned baby formula, that they don't have baby formula at home, or maybe they're okay for the next couple days. And if it takes a day or two, it'll be okay, but we need to support them as well. And so those referrals all go in our electronic system to the care resource coordinator team, who then is charged with the very difficult, complicated work where it's harder to write like a script and a checklist for this, right? This is a call the person, really figure out what does that family need, what are their kind of particular circumstances, gather that information, and then connect to the local resources, and make sure that we're always doing warm handoffs and following up. And John talked about accompaniment through this journey. So that's tough work that they do every day, all day on the phones and connecting to resources in the community. The next slide shows some of how this has gone. So when we hired all these people from across the state of Massachusetts, they all had deep knowledge and experience in the communities. And so we just started with them collecting all of the resources across the state. And I think, you know, this program has a huge sort of wealth of human resources to connect cases and contacts to resources. But what we didn't have was money to buy the food or deliver the food or build a house. And so a lot of this was liaising and connecting and trying to find ways to fill gaps any way that we could. And so the resource coordinators put together that 654 number is from last week, so it's even higher now. This sort of database where it's searchable by town, and we can depending on what somebody needs and where they live, we could find out what resources there are in that community. So the next slide, just wanted to give everybody a sense of how are we marching our progress? Like, how are we looking at the data in order to really think about what can we learn, how can we do better, and how can this inform the system in Massachusetts going forward? So we started with a lot of basic data just around what is the need out there, how much. We know that there's a lot, but how much is a lot, and what are the most important challenges that people are facing? And some of that came from simply asking people, are you able to safely isolate or quarantine at home? How many people were getting referred to our CRCs, and the sort of types of support that they were requesting. And what we have right now that we've started collecting is, of those, are we actually able to meet people's needs? And again, this is the tough work of not having the resources at our fingertips. We have the humans to connect people, but we didn't have the funding and the ability to purchase all of these things that people needed. So a lot of it was about connecting and learning about those pathways. So wanted to share a little bit of the results. If we go to the next slide, we've had so far more than 10,000 requests for social assistance, and that means that about 1 in 5 people with COVID-19 in Massachusetts do need help to safely isolate and quarantine, and around 11% of the contacts. So that's the people that are getting referred for help to the care resource coordinators. 6% report that they're not able at all to isolate and quarantine, and that is for a range of reasons, but a lot of them are lacking material needs, like those things you see in the list there in the bar graph. And 12% of contacts reported that they did not have a healthcare provider, because the contacts get called, they have to go get tested for COVID-19, and 12% of them are saying, I don't actually even have a healthcare provider to go to. So it's pretty striking inequity that we saw right away on the ground here in Massachusetts. And you can see the support that people need. Really, food rose to the top really across the state as the most common type of need. And then there's a large range of other things, cleaning supplies, PPE, overcrowded housing, people suffering from other chronic medical conditions that need prescriptions or medical equipment at home, people who maybe their caregiver is sick as well, and they normally have a caregiver and didn't and needed help. A lot of issues with landlords trying to evict people, sometimes because they couldn't afford rent and sometimes actually because they had COVID-19. So there's a large range of challenges that we meet that you'll hear more about in the Q&A. So the next slide. This is, again, just more detail on the types of referrals. I won't belabor this because I kind of said this in the last slide, but a lot of people struggling with food and needing financial assistance, people losing their jobs, and a long list of other things that you can see there. So the next slide. So early outcomes, this is in showing you this today, and hopefully our numbers will trend like this as we go. This is a preliminary set of data where we were able to capture, are we able to connect people to resources? And you can see there that 76% of these referrals in this sort of interim analysis were able to be linked to resources. And then 17% were able to be linked to some set of resources, but where a need was sort of partially met, but not completely. And then 6% we weren't actually able to meet the need that people were reporting. And the next slide. And then you can see here, this reflects a couple things. So this is the number of days between kind of when the person entered our system and when we were able to meet the needs. It's a downward trend, I think, for a few reasons. One is the case volume is going down. So we were not as underwater with the number of referrals. And two is a lot of the documentation and systems were improving, and we're learning a lot over time. So hopefully we'll continue to improve on that. And the next slide. And then just this slide, really what the punchline here is that that blue line is the curve in Massachusetts, right? There were a ton of referrals, a ton of cases, but what has been consistent over time is that sort of 20% number of people needing help really has been consistent over the weeks that we've looked at this. So next slide. I'll hand back over to John to go through some partnerships and then some more of the sort of qualitative experience that's arguably a more important piece of the data that we'll share with you here today. So go ahead, John.
Yeah, thanks, Emily. So, I think what's very important in this work that we're doing here in Massachusetts and the work all of us do around the world is how important our partnerships are. Pretty quickly, as we pulled things together, we reached out to and received outreach from so many different really important groups around Massachusetts, including the Mass League of Community Health Centers, the Mass Association of Community Health Workers, and other partners. It's essential to note that so much of this work is happening at the local level before COVID, and that really community health workers, public health nurses, and so many other public health providers fight tirelessly day in and day out to try and do exactly this work that we're doing, and do that in a really constrained environment, financially and politically sometimes. So I think that one of the things that we're seeing is sort of the amplification of that work, and also really opportunities like this for us to recognize those partnerships and recognize the great work of all of those folks around Massachusetts and around the world. And hopefully, if there's a lasting impact of this work, it is to note that this resource coordination, and really that through the equity lens, it has to be continually sort of brought to the fore. So we're really happy about these partnerships, and I think we're learning a lot from folks that have come on board from these different groups as well. We can go to the next slide. I'll just share a few notes from the field, and these are, I think, really at the end of the day, what this work is about. Emily showed us so much great data, but these types of stories, and we'll move through these so that we can spend some time in Q&A. But these are the stories of what it is that we're doing. And these are the questions I think that all of us asked as COVID really took hold. And we talked about things like working from home and schooling from home. Those things, working from home, schooling from home, isolation and quarantine, those are activities of privileged people, right? To be able to stay home and keep working, to be able to be able to school from home. And you can see that in this first story here, right? That these kids were home and didn't have Wi-Fi. I mean, think stories like this for me, I think about this and think, you know, when you hear commentary or read commentary that contact tracing isn't social support, that's exactly how we were connected to these people and exactly why we put the care resource coordinators in place. The other story, we can go to the next slide. I think Emily touched a little bit on some of the mental illness pieces. And I think all of us who've been providing care during COVID, whether through contact tracing or on the front lines otherwise, have noticed and would agree that some of the mental health problems that we see have just been heightened and are certainly increased. In this case of schizophrenia, the CTC was in touch with this person talking about their serious debilitating mental illness. And this care resource coordinator spent a lot of time helping to find the local resources and keep the patient out of the hospital. I mean, yeah, I won't read this to you, but this is the work that this is the work. And you can't, it's really hard to encompass in all the numbers that Emily showed us these types of stories. I think we have another, I think when the panel speaks, we'll be able to share some more stories as well. But I think what underlies all of this is that we've got to continually address the social determinants of health. And that's what the care resource coordinators are doing. Emily went through the needs of the top sort of needs that we see for people, but it's always taking that next step, right? We can address those needs at this moment, but what are we doing to sort of foundationally change the fact that those needs exist? And I think that is one of the most important things that we continue to work on as we improve upon our care resource coordinators, as well as we continue to refine our contact tracing efforts in Massachusetts and around the world, and look for long-term permanent solutions for a lot of these things. I'll also just quickly note, we're fortunate here in Massachusetts, I think, that when we have brought things like threatened eviction to really, to the highest levels in the state, that those, the Attorney General's office and others, they jump on those things and really fight and advocate for people. And I think, to me, it said that as long as we can continue to amplify the patient's voice, and connect them to the people who have the power to make change, that we're doing the right thing. And I think we're seeing that kind of one case at a time here in Massachusetts. We can go to the next slide. Really, I think this is just kind of to summarize what we've been talking about. A lot of my epidemic experience came from working in West Africa during the Ebola crisis. And, one of the primary lessons I learned was that the tools of quarantine and isolation will fail if we use force and fear. And we learned those lessons and continue to learn those lessons. that we have to provide for the human rights and the human dignity of the people who are isolated and quarantined. I think Partners in Health have learned these lessons: food security, housing, transportation. Since our earliest days in Conj, working with tuberculosis patients, the community is essential. And Joya says it all the time: all epidemics are local. And so the community is where the work has to happen. We have to continue to fight for public provision of healthcare and robust public health systems before, during, and after these types of crises. Contact tracing, case investigation are known epidemic response measures, but that always has to be bolstered by high quality care and social support. And really the role of leaders in any public health endeavor, but especially during pandemic response, should always first serve the most marginalized. If we're serving the most marginalized communities amongst us, then of course we're going to serve the rest of the population. And that's really, I think the way that we built our response here in Massachusetts, and I think what we continue to fight for and strive for. And I'll say that I think it's one of the reasons we've seen such success here in Massachusetts, is that we've really tried to found the work in social support. Next slide. So thanks everybody. Someone else will take it over from here.
So thank you all for the fantastic presentation, John and Emily. So much information packed in there, and we've had already a lot of great questions. So I'm hoping that we can hear from both Oscar and Shada, and then we'll also turn some of the questions back to you, Emily, and to John. But I think starting with Oscar, in terms of your perspective of being a community care coordinator, first of all, there were several questions about the difference between treatment and care as we're using it in this framework. What are you doing that is more care than treatment? There was a question about whether those 23 languages were across the world or just in the state of Massachusetts. And I know you speak a few of them. And just some of the, politics. And, one of the things I can highlight and foreshadow for all of you is that in our next session, we will be talking a lot more about the politics of survival and how we take these lessons learned and put them into an advocacy agenda for social change. And that's going to be a lot of the highlight for our next seminar, which is going to be on racism and COVID in the United States. So tune in for that as well. But Oscar, maybe you can highlight a little bit about whether CRCs are paid, what is care, did the website exist for social support, and just some of the general principles that you've learned on the front lines.
Thank you very much for those questions, and again for the opportunity to give my perspective. I've been a resource coordinator with the Massachusetts response to COVID since the very first week, the first cohort. I got co-trained as a contact tracer and as a case investigator, so I've seen kind of the whole life cycle. But why did I sign up for this kind of work? So as we discussed, PA specifically has expertise, global expertise in looking at health as a human right, regardless of where you're born, regardless of your zip code. I was born in the Dominican Republic. My family moved to inner city Boston, and I grew up in public housing, in Boston public schools, dependent on free lunch as a kid. My parents to this day don't really speak, even after 30 years in the US, English. We speak Spanish at home. And so when I signed up for this job, I actually they were looking for folks that had a social work kind of background, that understood the community, that could basically apply that global lens to Massachusetts. So I've actually worked internationally. You mentioned my languages. I actually worked in the Dominican Republic and on the Haiti earthquake response with PIH. This was an opportunity to apply that same lens to my own hometown. So Emily mentioned kind of how we get cases and case numbers that are then through a home assessment referred to our team as care resource coordinators. I see a number, but then I click on the number, and then it becomes a person. I've had cases to give to bring some of this to life, where the person got tested in the community health center where I got physicals as a kid, where I know for a fact my communities have been disproportionately impacted by zip code. It's been very clear. And so that's kind of the framework that really drew me to this model. And so in terms of the specific questions, I think when we're looking at the challenges, the treatment and care to make sure that we're actually flattening the curve. As John said, it is a huge privilege to be able to just isolate and quarantine without outside assistance. I've had calls with people who are undocumented, uninsured, and have been unemployed, but haven't had any way to access the public benefits because they're ineligible. So then they ask us, how do you expect me to stay home and protect myself, but others, when I need to go get milk at the grocery store? Or how do I get a prescription? I've had a case with, there was one individual who had been a victim of domestic violence and also had suicidal thoughts. So we worked in our technical working group on immigration with the other working group that was looking at culturally appropriate and specific resources for mental health to, talk through the options. And so when you ask about treatment, and again, we have to take a holistic model, I think what makes a good care resource coordinator and a contact tracing program comprehensive is understanding that every single person, in order to safely get through COVID and in the long term, maintain that we're all safe, we have to base our system in solidarity and compassion. And as Joya mentioned, one of my very first cases, it was just companionship. I remember there was someone, both of them were elderly, and they had they tested positive for COVID-19. Her husband was in the ICU and AD, and she was by herself because she couldn't even have direct contact with her children. I spoke Spanish and spoke directly to her, and she didn't want to get off the phone. It was just that human touch. And I think that's one of the best practices that you discussed. We are paid CRCs because we are dedicated professionals that full-time need to look at these issues and think through how to basically fill these holes in the social safety net. And again, there are politics involved. Again, there are systemic issues. But at the end of the day, I think what makes our experience an important one is that we do look at this as a human right issue. And it's ironic for me, being from Boston, from inner city Boston, this is a city that is very progressive, excellent leadership. And we know it's, the hub of, biotech. It has academic premier institutions, but we have not achieved racial equity at all, and health equity in our system. And so the fact that we're in building these new systems, acknowledging that fact, because based on the cases we all read, cities like Chelsea, in my own neighborhoods where I grew up, I've had some cases where at the end of the day, my last call was with a building in the public housing complex across the street from where my parents are currently living. So I feel this, I live it every day, and I grew up with it. And I think to those questions, it's not easy. And again, it's case by case, but I think ultimately our long-term goal is to build systems that can ultimately address these systemic issues and inequities that have been, laid bare and exacerbated by the pandemic.
So well said, Oscar. Thank you so much. And I think that also addresses a question about the knowledge, the knowledge of the local communities and cultures that the CRCs have. We've really been so fortunate to have people like Oscar who know these communities because this is where he's from, his parents live. And I think that is an important part of the Partners in Health thread around the world, is that we value the knowledge. So I always say to the team, community health workers are not community health workers, they're community health workers. We want more community. You know, we can deal with the health issues, but understanding the community is really a critical part to epidemic preparedness. I want to move to some of the questions that I think Shada would be, Dr. Shada Rouhani, who, as I mentioned, is emergency room doctor and was involved in planning of some of the services in the U.S. in our hospital. The emergency room led the way in a lot of the planning. But if you could, Shada, a couple of questions were about access to healthcare in the United States, capitalism, but I think talking about payment and the level of complexity that people faced early on. When you didn't have contact tracing, when you were really sitting on that surge every day, and kind of explain that compared to maybe what you would want to see and what you've seen as you're helping the PIH response globally.
Sure, thanks, Joya. I think those early days were particularly hard, and they were hard for obviously many different reasons. In a clinical standpoint, we were challenged by limited knowledge of the disease, limited access to testing, but some of the hardest challenges were around these issues that we're discussing today. It was when we would see a patient in the emergency room who we knew had COVID, but who wasn't sick enough to come into the hospital, who could go home medically. But for whatever reason, there were these huge barriers that prevented them from carrying out this core and they would disclose things like needing to go and pick up a free lunch for their children. And without doing that, their children wouldn't have food. Or living in a multi-generational household where they didn't have a separate room to isolate in or a separate bathroom to use. And these challenges were so apparent early on, and yet at that time, there was such limited ability to connect these individuals with services. And we saw the negative effects of this on a daily basis. Joya, you said at the beginning that some of the loudest voices in our ears are those of our patients. And our patients who are most effective are the voices in our ears. And for me, the voices that I still remember are the patients who shouldn't have gotten sick, who had a family member with COVID, who cared deeply about their loved ones but couldn't safely isolate. And as a result, others in their household became sick. And we took care of families where we would take care of the mother and then their grandmother and others in the household and people who lost multiple generations of their family. And so the need for these supports is so necessary for the clinical treatment and for the care of each individual patient and for the control of the outbreak as a whole. Addressing the questions about kind of access to care within the US system. Joya, that slide you put up at the beginning with the complexity of the US system, it is certainly a complex beast with many, many different aspects. That would take days. An important thing for the global perspective and also for the perspective of making contact tracing work is that one of the core things we needed to do within the Massachusetts response was find a way to help connect people to care when they didn't have care on their own. And so one of the key components of the CRC work became creating pathways to help patients access both urgent care for their acute COVID-related concerns, but also long-term care. And that ended up being a very local response as well. It ended up being calling and talking to health facilities around the state, leaning heavily on something called federally qualified health centers or community health centers, which exist around the US and are very deep patients. And working with those organizations and clinics to find ways to help the people that we were identifying through contact tracing case investigation reach medical care, both for their short-term needs, but then also to plug them into long-term care to try to address inequities that existed pre-COVID that we want to see eliminated.
it's so important to hear that perspective of what it's like to provide high quality hospital care, right? But without the community supports. So someone had asked, what's the difference between treatment and care? These are artificial distinctions that we're using rather rhetorically. But the rhetorical reason we're separating them out is if you think about treatment as a more biologic and medical phenomenon, we often talk in social medicine about the biosocial approach, which is what are the biological needs, the medicines, oxygen, etc. And Shada is a practitioner of social medicine, as we all are. So she's in an ER that's really geared toward providing the biological with the real neglect of the social. So we're using care here as the social. And we know that no matter what bacteria, no matter what genetic mutation, no matter what problem is the biological, that it's existing in the milieu of the social. And so again, that's really the root of this set of courses that we're doing here is how do we think about this in a time of a pandemic, and how does it lead to longer term responses? There were a few questions, and hello to Alice Johnson, who I know is from Last Mile Health, and thank you for tuning in. A few questions from people living in Africa and elsewhere in the global south, which I like to call not poor countries, but impoverished countries, because the wealth of the United States exists at the expense of the resource extraction of the global south, the material resource, the human resources, the ongoing brain drain. And so the question from Alice and others is, well, this is great, but how do we do this in a more constrained environment or an impoverished environment? And first I would say, tune in for session 4, because you're gonna hear from Rwanda in great detail, and there'll be a lot of questions there. And there were a couple questions about, forced quarantine, martial law, and things like that. And I think our Rwandan team will be happy to address those specifically. There is, I think, an important leadership aspect that can be perceived as heavy-handed, and we see that right here in Massachusetts. People think even a mask order is martial law. So I think we have to think about leadership in public health, because some of it is related to how it is communicated. And I feel that the good leaders, the great leaders in this, have communicated these decisions, whether it's mask wearing, social distancing, as something that is that we're in it together, that we're saving one another, that we're protecting each other, versus something more heavy-handed, or just not making a decision at all and saying, doesn't matter if you wear a mask, doesn't matter if you go to a bar. And so I think we are dealing with these, so that leadership can exist in any country regardless of the resources. So that would be one answer I would say. But I would turn that one maybe over to Emily to say, how you've been working in Africa prior to this for many, many years. Tell me how you would see, can we do this in an impoverished country like Malawi? How is Malawi faring? And what are the successes and the challenges?
I mean, can we do the CRCs in Malawi?
Any of it.
Yeah, definitely. I actually, spinning it around when we started getting like all these calls from the media, and the first thing they would say to me is, you've been working in Africa, how is it different in Massachusetts? And honestly, it isn't that different, in that there is tremendous inequity. There are a ton of really important stakeholders, and it is really complicated. But that we have to start from hope, optimism, and a mission toward equity. So like that, but I definitely think that this sort of work is possible in Malawi because I've seen it, right? I mean, I think a lot of people on the phone work in countries where there are dedicated community health worker and paid professional community health workers who understand the people that they're serving, are often on the ground by foot doing home visits and seeing the devastating effects of poverty and helping support people. So I think, the other thing I'd say about Malawi is that it is impoverished and there's not enough money in the system, but the political will is there in that at public health facilities, there aren't user fees. So in some ways, leadership, in a lot of these places is starting from a place of commitment to care provision in a way that isn't sort of market-based like the US. So I think it's definitely possible, with the caveat that we have a lot of work to do to kind of address global power structures, right, and distribution of resources in an equitable way. But I think that the political will is there. I think the leadership is there, and certainly amazing dedication and talent on the ground. And I've seen a lot of really amazing socioeconomic support programs that are happening in Malawi, in Haiti, in a lot of the places where we work. And that's actually what informed a lot of the design of this program, was bringing those lessons from work that myself and many of my colleagues have done in the Global South to Massachusetts. So thanks for the question, Joya.
Yeah. So a couple people, obviously from the US, have asked about the Boston Globe article that came out today that was quite critical. And I do want to address that, right up front. First of all, we never at Partners in Health have an illusion that anything will be easy or conflict-free. Like, it is a messy situation in the middle of a pandemic to try to help a very disempowered set of public health, departments that have been gutted for 40 years, to deal with the most vulnerable, and to have, a perfect sort of political posture in all of this. And so this is always complicated. This is always really complicated. And one of the most important things I would say, and I'm going to ask some of this to John Welsh, is there's a question about communication. And I think one of the problems, one of the struggles we have in the United States, and somebody asked about capitalism, which is, by the way, one of my favorite questions. So I love that one, but is fragmentation. In the state of Massachusetts, we have 351 boards of health, right? We are the size of Rwanda, so smaller, actually, half the size of Rwanda. And imagine if and Liberia is also, half the size of Massachusetts. Imagine if there were 351 autonomous bodies making individual decisions. So that sets us up to have huge challenges with communication. So we've tried to do a lot of it voluntarily. If you need our help, we'll help you. Sometimes it's been, some reluctance because people want to do their job, right? And most boards of health want to do their job, and they've been overwhelmed. Some are not overwhelmed because some are in smaller towns that have fewer cases. So, when we see an article like the Globe that, talks to 3 people and makes these generalizations, I think it's really missing the boat that the problem is the fragmentation of not only our delivery system, which Shada has highlighted, but our public health system and the interface between those two systems and the social support and social welfare system. So, for example, in Malawi, we've long worked to provide social supports, but we work with the Ministry of Social Welfare. And so there's a coordinating body, but this level of coordination in the states has been specifically disrupted by privatization and other things. So, John has been working on a lot of the communication with boards of health, and maybe you can talk about the successes, the challenges, what you've learned, and comparing that a bit to Sierra Leone.
Yeah, thanks, Joya. I mean, I was just yesterday on a call with the assistant health director in a pretty large town here in Massachusetts that has a catchment of 100,000 people. And they have 2 part-time public health nurses that work, each of them are paid to work 10 to 20 hours a week for 100,000 people in the middle of a pandemic, right? I mean, that is what the public health system looks like right now, So one of the most important things that I've learned is that those public health nurses and those health departments are fighting like hell to try to respond. And, sometimes this sort of centralized effort to provide for one of their essential sort of activities, that is contact tracing, on the surface can feel a little bit like it's complicating things for them, right? But I had a conversation with one of the health directors in Massachusetts pretty early on in this, trying to understand what it was that we could do to help, right? Like, how will contact tracing help their town in particular? And he said, John, for weeks we've done whatever we can to try to build a sandcastle. And he's like, what a lot of people don't understand is that in public health in my town, it's not just contact tracing or epidemic response. It is, certifying that restaurants and hair salons and all of these places are safe, responding to other types of outbreaks, just so much work. He said, we have tried to build this sandcastle. I've hired part-time people. I've rearranged my budget all around COVID. And he said, we have seen for the last couple of weeks, the waves start to lap at the base of our sandcastle. And he told me, until last week, we came in and the waves had just taken the entire sandcastle away. And what the CTC is, like what the endeavor here has been to build a wall and build a moat and build a barrier around that sandcastle to say, we're not going to do this perfectly, and we aren't, but we're here to allow you to continue your essential activities, to keep serving your the folks in your town. And this person was devastated that the sandcastle was ruined, because he felt like he was failing, not himself, but failing the public, right? And so those are the lessons that I have drawn on to try to continue to do this work, even when sometimes, I don't get the communication quite right. And so, and what did that look like in Sierra Leone during Ebola? That was spending long hours with paramount chiefs and village chiefs and faith leaders, trying to understand what does this response look like for you? Here's what we think will be helpful, but what does this look like for you? And I think we're in this moment in Massachusetts where our case numbers have kind of trickled off for a little bit, and we hope that they stay there. But this is our opportunity to reiterate on what we've built, to reincorporate some of those, that input and that advice, and really now bring public health along in this effort. So, and it's constant, right? It's not a one-time sit down. Here's what we'd like to do. What's your input? Okay, moving on. It's sometimes daily calls with local health departments and health directors and public health nurses, and they all have my phone number. We talk often, and it's what you have to do. And if you don't get it quite right, you just keep readjusting. Yeah.
So thank you, John. And I think we're sad about the Globe article, but again, it's easy to poke holes in people trying to work night and day, and it's much harder to actually do the work. So I want to turn, I think, probably the last question to Oscar about a good question, I think. How do you, and I think this could go to all of you, Shada, Emily, John, but I'll ask Oscar first. How do you manage your own mental health in this? That was one question. And then the other is about crowded living situations. And I think for those of you who've not been to the United States, it's a bit shocking when you see homelessness. For those of our friends and colleagues who've come, to see the number of homeless people in the United States is quite shocking. And this is something that is also driving our epidemic. So if you can talk about housing as an issue, Oscar, and then also your own mental health.
Great and very important question. So I'll start by saying, this is all unprecedented, stressful times for all of us. And for CRCs, we actually got training on psychological first aid from those who, as we've heard, have seen it on the front lines in the ERs, have dealt with COVID, just letting us know how to support those on the other end, but also make sure that we have, at the end of the day, in mind our own self-care, and that's primary. So we still are encouraged to take a moment, have some perspective, walk out with your mask, social distance, but take a breather. And just a related point, so it's very critical to keep in mind that we've been talking about communication. I think one of the primary barriers that we've seen is when people have hesitancy to pick up the phone because of this sense of fear. Who is calling me from the other end? To what extent are there going to be, victims of scams, fraud, or to what extent is our information going to be protected? Because basic information only if they do need isolation housing because they're living in a multi-generational home and can't safely isolate. If we need their address so that we can deliver food via maybe a volunteer that we've been liaising with that's going to deliver food from a food pantry or even buy groceries for them and deliver it. So there's hesitancy because we have the information from their positive test result, but then we have to maintain that trust because sometimes the initial, specifically with the immigrant population or low income already, at-risk communities, marginalized, we're an authority figure by default. And so how do we build that trust? So again, it's doubling down on trusted partners, beginning from a place of compassion and starting with just the question, how are you doing? We develop, I think you read in the case that, in terms of short outcomes, but we're doing this accompaniment throughout a couple of weeks or longer. We get to know these individuals. We know their voices. They know ours. And so we have to make sure to nurture that kind of trust. It's our most important currency in this. And then when we're handed these very difficult cases about housing. Very briefly, my working group looked at a detainee that was released and tested positive for COVID upon release, but had no housing. So we had to work, to get him culturally appropriate food because what he had in detention was not what at all he was used to. So made sure, and now that he was going to be with family, that we addressed the food need first and then the housing need. Massachusetts, luckily, has come with alternatives, hotels that have been retrofitted to become basically emergency isolation units for those with COVID-19. So we've been able to develop these partnerships. But again, it is all founded upon the idea of, having clear communication and building that trust. And doing so through direct communication in their language, having cultural humility, and when possible, I think the case study also talks about our virtual town halls. We go on the radio, we let people know we're here to provide you information on how to safely quarantine and isolate, but also give you a helping hand, provide that social support when needed. It's all interrelated. And then the complex cases, when you talk about housing, when you talk about all these other issues, it has to start from that same place.
Thank you, Oscar. And I'm just wondering, I just would love to hear from Shada, just because I know that many of the countries that are people calling in are going to be facing a big surge, and you were providing care in the middle of that. And can you talk a little bit about mental health practices that you or others provided, how your team fared, the team-based dynamics? I'd just love to hear that as we close.
Sure. Mental health is obviously a huge part of the COVID pandemic, and it affects everybody. It affects the patients with COVID. It affects those who are patients either as care resource coordinators or as clinicians. On the clinical side in the emergency department, we made some very deliberate efforts to put mental health supports in place through the form of debriefings, group nightly sessions that people could opt into and call for peer support, resiliency training and resiliency support for all staff. And that means not just the physicians, but it means the housekeepers and the respiratory therapists and the nurses. And many of those similar themes have carried over into peer support programs within the have done around ensuring that there is grief support and other support for patients that we take care of as well.
Thank you, Shada. And I note that Dee Dee Shiano is on. She was not initially on the panel, so we didn't prepare questions, but Dee Dee, we have a little time for you to make a comment. Please tell us the role that you have been playing and what you'd like to add. No, can't hear you. Sorry, we're not able to hear you. We'll see if we can get Dee Dee back on another. This was kind of a last minute, so we didn't do the check. Can anyone help her from the Amy or others?
Dee Dee, are you muted? Can you unmute?
She's not muted. It looks like she's trying to unmute and still no sound on the.
I've changed the settings on my end, so I'm not sure.
It's okay. We're gonna have her in our office hours so she can.
Yeah, we can have you join after. We'll try to work on the sound issues. So, you know, I think you heard a lot. Just to summarize, I mean, I think first of all, what I always say to everybody is the work's messy. It is not linear. It's not perfect. It's messy. That's how we dig our way out of epidemics. And if anyone thinks it's a straight shot, they're fooling themselves. And so we always expect a lot of challenges. Some we can anticipate, you know, how difficult it is to convince everyone of going in the same direction. Those we can anticipate. Others we don't anticipate as much. And part of it is working together as a team and protecting, you know, our own mental health and the mental health of our team. What you heard here is really the human-centered approach that is focused on equity and how much attention to resources and the social context is linked into our work at Partners in Health. I believe many countries can do this. Many countries are doing this far better than the United States, obviously, when you look at our trajectory. So wealth is not, you know, equated with good pandemic response, and wealth of a nation does not equate to wealth of a public health response or of solidarity. And so I think many countries have more wealth in their communities and are able to tap into that. And so, you know, and I think great partnerships across. So even though all partnerships aren't perfect, you know, as John was talking about, the 351 boards of health, the Department of Health, the local communities, food banks, you know, immigrants' rights organizations, these have all been part of the mix as we think about the response, and will continue to be. So I'll turn it back over to Mansi and Phaedra to let us know what's next for us here. And just to say that we will be diving even further into the challenges of racism in the United States and how racism impacts the pandemic. And I think that will be very enlightening to many of you who don't live in the United States, and also to many of you who do.
Thanks, Joya. Thanks all the panelists. This was really amazing. I would like to remind you all that, you know, this is just the end of the session. It's just 90 minutes, but after this, we will take a break for 5 minutes. And after that 5 minutes, we will have office hours. So it's optional. If you want to talk more to individual panelists or you have more questions, please join that session if you can. So in terms of next steps, we have 2 more sessions coming up. So it will be Tuesday and Thursday of next week. I will invite my colleague, Phaedra, to give a little bit of overview of the next session coming up. And then I will invite Amy to talk through the logistics for the next session. Phaedra?
Thanks so much, Mansi. And thank you to all our panelists and speakers. I think it was an excellent session. I hope all our participants enjoyed as well. There's tons of great questions, a lot about admissions at UGHE, so I'll just direct you towards our website, ughe.org, for more information about our programming. So as Manzi mentioned, our next session is on Tuesday, and it is going to be a focus on inequity and racism. And participants will review and discuss equity dimensions and integration for effective public health responses to COVID-19 and other pandemics. They'll again examine the role of policy development and advocacy as a means to address health systems gaps. As with our last session and this session, we will reinforce the role of public health implementers, policymakers, and civil society itself, as well as understand the roles and responsibilities of current and future leaders in eliminating social disparities in the context of pandemic preparedness and response. Based on 2 practical case studies, one of the Navajo Nation in the United States, as well as on racism and equity in the United States, our faculty and expert panelists will discuss equity integration, again as a core strategy to address and recover from COVID-19 and to build sustainable systemic change. So I'll now turn it over to Amy to talk about the logistics.
Thanks, Phaedra. So as you see, our next session is on Tuesday. You do need a new Zoom link for that. It's included in the Outlook invite that you got from Melissa. And then also we'll put it into the website as well, and we'll make sure that all the session 3 materials are up and going by the end of today. All the materials can be found at that course website, all the materials from session 1 and session 2. The recording for this session, for session 2, will be on the session 2 website, the subpage towards the bottom, and it should be up there in just a couple of hours. And then for this session, in order to get certification, you do need to complete the assessment survey. There is a link to that also on the website under session 2. We'll try to put it in the chat function as well in just a minute. Next slide. So we're going to take a 5-minute break before our optional question and answer session. Please go ahead and submit your questions in the Q&A function, and we're going to be reading through them and giving them to our panelists. So thank you.
Thank you all. Thank you everyone for joining. So those who are staying for office hours, we'll be right back. All right. Thank you very much, everyone, for staying. I see we have over 500 people who stayed for office hours. This is really good. I would like to check in with Joya. I see Hannah B. I would like to make sure we have we are still on for the questions. I know we have many. Again.
Great. And I think Dee Dee was going to try to be on her phone. Is she on?
She's logging back in with a panelist link.
Okay. All right. So, thank you all for staying with us for this long period of time. I think there's so many questions about the resources and, where they came from. Can we do this in poor countries? And I would just say that I would say that this is really about political choice. And what we've seen in the United States is the political choices that have been made at the federal level, which are very poor, have led us to be the epicenter of the world. And the political choices state by state have shown huge differences between states. So money is not really the issue. It's about the political choices made with the money. I mean, money is part of the issue. And don't get me wrong, it's not like I don't understand what Liberia is facing, for example, or Malawi. But I think that and you'll hear more of this from Rwanda about how political choices can be made to support this early on, so you don't end up dealing with the disaster that we're dealing with in the US. We have Dee Dee with us. Do you want to give a comment, Al? Let's see if we can hear you. No, you're on mute. You're on mute. You're still muted. Try again. You want to try putting in headphones, maybe. Okay, so there are a lot of different questions coming up. So will you talk more, Oscar, about the importance of language? Someone said, do you really need 23 languages? Tell us about the importance of language. What does that mean to you?
So we need a lot more than 23 languages, actually. This, again, as you mentioned, it's case by case, state by state, municipality by municipality. But I worked specifically on the Boston team. Again, we were geographically assigned and focused. In Boston, again, there are certain neighborhoods where the majority don't speak English at home. I talked about my own family experience where the language barrier is something, it's generational, but also linguistic in many homes. I think in Boston, and this was based on the last census 10 years ago, there were over 140 languages spoken. And there are 6 languages that we in the CTC program have constantly seen as spoken by that community that's been disproportionately impacted. When my working group looked at, what are the challenges that specifically immigrants and people of color are facing, again, there's the legal barriers, but then there's always that language access. Even in a state like Massachusetts, where there is that political will, there might not be easy access to applying for unemployment benefits, even if you're eligible. Maybe it's only in English, or they rolled out a program in Spanish, but what about Cape Verdean Creole? What about Haitian Creole? What about Vietnamese? And again, that's where we come in, because we ourselves may have those language skills. There is a dedicated language line through a contract that from the beginning, contact tracers, contact investigators, if they don't speak the language spoken at home, it could be a Khmer, it could be another language that maybe someone on the staff doesn't speak it. And so there's a dedicated professional language line that assists. It's critically important, because if we're going to accompany individuals, we need to speak their language. We need to make that cultural connection as well. And I personally, my background is in public policy and in trying to assess language access. So as I mentioned, one thing is to have a public awareness campaign about the importance of answering the call in English. via LinkedIn or certain platforms. But if you want to be really effective, we have to know the voice of, you know, who we're serving, who we aim to serve, and speak in their language. So again, direct community engagement through trusted partners. Language is, for me, primary.
Great, thank you, Oscar. I'm going to turn this over to Emily, give you a chance to respond to the Boston Globe article, the critical nature of it, and would be interested to hear your thoughts, Emily, on some of the flaws in the article, but also, you know, what you think we could do better and what lessons you've learned from being, you know, flying back from South Africa in diving into this. Yeah.
Thanks, Joya. Yeah, it was definitely kind of gut wrenching to read that article, but I think that I don't know if I can say it better than you said it, Joya, honestly, that this work is messy and it's complicated. And of course there are challenges. Obviously there are challenges, right? It's a pandemic. And I definitely remember we were like 3 weeks in and it felt like we were 3 years in, and we had done the type of work and documentation and teaching and training and program design and all of that, phone calls, and that normally you do in like a 12-month period, right? So I think this has been really difficult, and I feel very grateful to be on the team trying to make it work and trying to stop community transmission. And I think, you know, so it, you know, it's one article, and I think what gives me comfort and confidence are all of our colleagues and all of the work that's been done and that's being done. And the numbers are actually really good from the CTC. You know, we, at the beginning in April, let's say we're having trouble getting like 15 to 20% of people to pick up the phone because people don't like to answer their phone when they don't know who's calling. That number is down at 5% right now with the town halls that Oscar mentioned, with all of the different programmatic things we've put into place. And so so some of the article stuff was just sort of incorrectly reported. In that we are able to kind of reach out to everyone, try to get a hold of them in the first day that people come into our system. Which brings me to one of the challenges, I think, in contact tracing generally and for COVID-19 in particular is how quickly it is important to get to everyone. And so one of the challenges is with the sort of the way the data flows in these electronic systems. And it takes, from the time somebody gets tested, it can take kind of days for them to hit our system. And so there is that delay. That delay is out of our control at the CTC, but it is an important one. And there's a lot of people that are looking at that. It has been improving. The Department of Public Health has a lot of data around this. So I think that's a known challenge that everybody's working really hard on, that kind of happens upstream of where the contact tracing system is happening. So that's like a couple thoughts, but I feel really proud of all the work the team's been able to do, and the numbers really do speak for themselves, and I'm just grateful to be part of the team. And we'll meet lots of challenges, we'll meet lots of critics, and we just got to keep going because it's the right thing to do and it's really important.
Yeah, it's always a question for me, do you respond to that kind of sucker punch? You know, we've done a lot of work that we're insanely proud of, but we also know is imperfect. So John was very involved in the work in Sierra Leone, and we were the only organization that was willing to go into a government built facility. Everybody wanted their own purpose-built facility. Was it perfect? No, it wasn't. We had some infections. We got called out in the press. We also treated and saved more than 1,000 people before one single purpose-built facility was put up. And that's, to me, a lot about what we're seeing in the US. Somebody asked, is contact tracing happening? It really isn't, not at scale, only in mass. There's some now in New York, there's some in Connecticut, Rhode Island. So I don't know, John, if you want to comment on sort of, I mean, you did already, but maybe some of the sort of parallels that you've seen between the Maforkey work, this work, and, you know, the sucker punch?
Yeah, I think the number one thing is that you just have to start, right? We did that in West Africa during Ebola. We are not an emergency response organization, but we always have responded to emergencies in the places where we work. The Ebola response was new for us in that we entered into 2 countries simultaneously to respond to Ebola out of the moral imperative, right, to do so. The same is true with COVID, right? You can criticize us all you want. You can call out weaknesses or any sort of problems that you see, but the question then you must ask is, number one, what's the end game there? And number 2, what are you doing, right? And so if we just start, right? We start doing the work, and then you iterate and you scale and you iterate and scale. I mean, this is what's important about doing the work. And I think the same is true in West Africa. I mean, Joya, you said it, that we were the only organization. I mean, I remember the first time I saw Maforki, and there were just sort of dropping off people out of vehicles just into the central sort of area of the ETU. Mm-hmm. Meanwhile, the hospital there in Port Loko had been overrun with Ebola patients, and at some point there was just no longer any sense of who was an Ebola patient, who was there for something else, and that's what turned people away from seeking healthcare for everything else, because they were afraid. And so, as an organization, we stepped in and we said, we're going to work together with you to bring this hospital back to what it is you need it to be as a community. Working with Dr. George, who we recently lost.
COVID. Rest in peace.
Who just worked day and night to serve his community. And we were there to try and help him do that, right? So I guess my response is, for the inaccuracies, we will work to correct those inaccuracies in the piece, but it's just sort of a catalyst for us to keep going, right? Like this is the work we do. It's messy. It's we thrive in complexity. And what that article described to me is how insanely complex it is to try and respond during this time. And so, thank you for the call outs for things that we should work on. Thanks for the opportunity to actually share real data with the people of Massachusetts and around the world. And we're going to keep going, and we're going to keep working to make things better.
Joy, can I ask you a question?
Go ahead, Monty.
Yeah.
Yes.
So I think maybe I have one for you, Joya, and maybe another to Emily and John. So one question would be, when you mentioned the human-centered, contact tracing. So what is a non-human-centered contact tracing look? How would that look like? So it would be really good because they exist.
That's a good point.
There's a human-centered, then there's a non-human-centered. It would be really good if you could talk more about that, and people could learn from there. John and Emily, I think I'm really interested in really knowing, how do you train and validate the care coordinators or contact tracers? And you say you're ready to do care coordination or contact tracing, because I think in terms of the course, I think many participants would love to know that. And if there's any resources at all, the source of materials they can refer to, please feel free to clarify that.
Yeah, I think that's a great question. What is human-centered versus non-human-centered? It's an awesome question. Thank you, Monzi. You know, what we think is human-centered is trying to address the needs of that individual person rather than looking at public health for only the benefit of the community. So I think that, you know, historically public health, and, you know, if you look at definitions, it's about population-based things on aggregate, but we know that in the disaggregated data are individuals and individual struggles. And so when we think of human-centered, it's taking these public health principles, but understanding how they relate to one person and their ability. So, you know, you can have, let's say, and we found this a lot, I'll use an AIDS example as I always do. You know, early in the AIDS crisis, we would say, you know, just use a condom or just say no to sex. And what we realized in many contexts is that for girls, young girls, particularly in very high prevalent settings, they were already orphans, school was not free, and there might be somebody who wanted to have, you know, sex with them, but was willing to pay their school fees. Well, they might make that choice. And we talked about this a lot in the first session about the difference between real choice and having the agency to follow up. And Phaedra really highlighted that in her excellent summary. And so I think when we talk about human-centered, we're really trying to dive into what agency does this person actually have to protect themselves and their families. And yeah, and I just, before I turn your next question over to John and Emily, I also wanted to hear, you know, in terms of lessons learned, Phaedra, maybe you can give us just a little sense of how things evolved from the provision of care over time, because it's not only that in contact tracing we're learning lessons, in the ER you were learning lessons, right? Even at the esteemed Brigham and Women's Hospital. So maybe if you can sort of talk a little bit about how things changed, how they improved over that for 6 months in some, you know, big broad brush.
I have an answer to what non-human centered contact tracing would look like.
Okay, jump in. Yeah.
Very straightforward. It would be an app, right? And it would be like a checklist of like tick, tick, tick data entry with no human attached and no sort of individualized approach without any acknowledgement of how difficult it is to isolate or quarantine. Great. And so I say that a little bit in jest, but in reality, like, yes, we've been approached by hundreds of tech companies, and put simply, like, tech can make things better and more efficient and is excellent, but only when partnered with humans and a human-centered approach. And if tech was going to save us all by itself, it would have done it already. That's kind of my thinking. So I think the sort of, you know, tech's involved in a human-centered approach, but that was kind of, I thought you might like that, Joy. I was like chuckling when Monzi asked that.
Gadgeteers, the gadgeteers.
Monzi, your question was, how do we train people at the CTC, right?
Yeah, I think training and the validation is really important.
Yeah, no, that's a great question. And like everything else that we do, it's been sort of ongoing and very iterative because we needed to start so fast. And so we started with a lot of sort of Zoom, right? And on other online platforms, lectures with the core content for the sort of workflows for contact tracing. And we just from the beginning sort of welcomed everyone to build the program and learn with us, and thanked them for their flexibility and an ongoing sort of learning environment, because we knew we were going to add more and more material as we went. So we started with just sort of the bare bones, and then used a lot of the experience on the phones from the early staff and the questions they were asking and the complexity they were seeing to inform more and more learning and teaching materials. And so my eyes went over there. I have this big whiteboard over here that has like a big long list of protocols that we're writing and revising and different trainings that we're doing. But I think it's been, and using the staff really to tell us what we haven't taught them yet and what they're seeing and what support they need. And then doing kind of smaller group things, larger group things, recorded things that people watch later, some role playing, like a lot of different like techniques that we can in this sort of virtual environment. but that's kind of how we did the training. And a lot of what I'm talking about is the contact tracing part of it, is the epi and the public health pieces of it, of case investigation and contact tracing. For CRCs, the honest answer is that they taught us, right? Like, we hired amazing professionals with a ton of experience doing sort of this kind of work in different forms. And we all just kind of learned how to do it together with the goal of identify need, try to connect to need, solve problems together. So there aren't scripts and protocols and that sort of thing that are easily applied to that work, but there is a ton of content expertise on our team. So most of the training materials for CRCs have been written by the CRCs themselves from there. So welcome others on the phone who worked on a lot of those materials to comment too, but maybe, I think John, you were next, and Shada, and anyone.
I was only going to say that I just love your whiteboard. Like, I'm a bit envious of your working whiteboard. No, that was great.
Great.
We have, I mean, I'll just say that our training team is sensational. We're so lucky to have, I think, probably one of the best training coordinators for this kind of work on the planet. She's ours, so nobody go after her, but Bradburn is just amazing to pull all this stuff together. And you know, she reminded us yesterday, actually, that she did, after a couple of weeks, she did a nice training assessment and needs assessment, which, you know, indicated that kind of this need for the speed that we were working with, actually could have been sort of hurting our capacity to really provide the level of care and level of support that we wanted. And so we kind of took a step back and spread that training out, and that made people feel much more prepared to do the work. So, you know, in slowing down the amount of spreading out that training, I think really helped us. Monzi, you were asking about sort of validation, and I think that was one of the most important exercises for us. People just reporting to us, like, I'm ready. I'm ready to do the work. And so when we try to pack that training into a couple of days, they didn't feel quite ready. Really spreading the training out over 3 or 4 days, they said, okay, I'm ready to do it now. And that was really important.
Yeah. I had asked a question to Shada just in terms of the iterative learning. She's been involved in training people in critical care around the world, but also even in the US. How did the response change? What lessons were learned, and how do you see that impacting the public health strategy as well?
Yeah, there's definitely been lots of lessons learned, both, you know, technical medical lessons learned and trainings and iterative processes there. But then talking about this human-centered determinants of health, one of the biggest things that I have seen on the hospital side change over the course of this response is an increasing recognition that there is a need to focus on social determinants of health throughout this. Many health systems have put into place callback systems where they call patients after their diagnosis. And initially those questions ask, are you feeling more short of breath? Are you having higher fevers? And over time, we saw that even in the Brigham and Women's Emergency Department, we put into systems to ask questions about, are you able to safely isolate? Do you have food? I hope that these changes to incorporate these social determinants of health will carry over in time, and that they will become a more ingrained part of our system. And, you know, we talk a lot about quality improvement in medicine and public health, and that involves this process of critically analyzing what you're doing, finding the areas for improvement, and then iterating on that process. And I think we've seen within the medical structures expansions of community-based testing in the most needed communities, expansions of these social supports in response to identified needs during this pandemic. And I hope that those will continue.
Thanks, Shada. I mean, part of the reason I want to bring this up is, you know, again, relating to the Boston Globe article, relating to the level of complexity in everything we do. You know, even if you have one of the best hospitals arguably in the world, there is a learning process that goes on in the face of a pandemic. And so that's the way we approach the work. we learn from, as Emily was saying, the people who are on the front lines that we've trained and hired, we're being trained. You know, we believe in the really bi-directional nature of learning from people, communities, patients, and the epidemic itself. You know, we didn't think it was airborne. Now it may be airborne. We didn't think masks would work. I mean, there's a lot of learning. Oscar, I'm wondering if you can talk a little bit about stigma, because and how fear is generated. How have people dealt with stigma? There's several questions about stigma in the chat.
Happy to address that. I might have mentioned in the main session how one of the first challenges that we saw as contact tracers was, again, getting people to pick up the phone because of, again, that instinct of whether or not, who's calling me, is it going to be a scam? So there were specific public awareness campaigns on TV, social media, saying answer the call, making people know that it's going to be with a specific caller ID. The Massachusetts COVID team is linked to, and we're going to protect your personal information. But even before that, I mean, we're living in a culture of fear to an extent where there's a lot of misinformation. The WHO, again, called this an infodemic, where misinformation is just as dangerous in many ways as the virus itself. And there's just, again, a lot of rumors and stigma. Even before I spoke about this in a more official capacity with the CTC, just at home, there's just a lot of misinformation about how to treat it, how one can be exposed. What is the difference between quarantine or isolation? Does it matter? Can you share a mask? There was just a lot of misinformation, basic facts that were not understood early on. And so again, we were very intentional about spreading facts and making sure that we do it in platforms where it could reach individuals. And I think, just to answer the question on training, I've been floored by the expertise of my fellow care resource coordinators. And again, I think the challenge was to build, they kept calling it an army of contact tracers. Even if the governor of New York used that same term, do it as quickly as possible. And when I was on one of these campaigns, I was on a radio interview in Spanish in Boston's, I had the largest reach in Boston. And I actually got one of these gotcha questions. So it's early on, but how would you already rate the CTC from a scale of 1 to 10? And I said, if your measure of success is, going on the offensive, social distancing, staying at home, that's a defensive. If we're gonna go on the offense and try to trace down this virus, try to dispel misinformation with these Mythbusters campaigns, I give it a 10 because it's better than nothing and it's what we need. And I think early on, again, we acknowledged that we just had to hit the ground running and then, tap into the resources internally, and then again, build on those that we've identified in the communities themselves.
Great. Thank you so much for that. I'm just looking at the questions, and I wanna flag that we haven't been able to get Dee Dee on, but Dee Dee is on a number of our Massachusetts team currently, and past, Benita, Finn, Art, and we're just grateful that people have answered the call. And I also want to point out that, and Emily alluded to this, but part of the ability to surge and go down was the plan. So we had the plan based on what we anticipated, knowing the epidemiology of COVID, how the cases would go up, how many contact tracers we would need at the peak, and hopefully turn it down and then have fewer contact tracers. So that's not at all appearing anywhere, but I think as we are trying, we have money to try to help and support other states, other cities, community organizations across the US. And this is the message. It's not just a set number of people. It's really a number of people who can be flexible, who can meet that demand and then have it come down, but then be ready. There's several comments on schools, and I don't know if any of you want to take a shot at answering those comments on school opening and how these programs or others may connect to school opening. Anybody want to take those? We're all scared of it.
I can only, oh, Didi, I see that you went unmuted. I'll
You're gonna try again. Didi. Nope. Sorry. Go ahead, Oscar.
So as I mentioned, so actually I grew up in a daycare in Massachusetts. My mother has been a daycare provider from our own childhood home in Boston. And so one of the most challenging cases that I saw was a frontline worker, you know, a nurse who tested positive for COVID, and she had a 10-month-old baby. And then her mother was the person that took care of this child. And her mother passed from COVID and then needed our support because once she was done with isolation, she was, you know, going to go back in the front lines to protect us all, but then needed information on childcare. And again, I knew from my mother has worked with the early childhood education department. And there was a specific list of daycares that were open specifically for healthcare workers. And so it was my task to say, where's your workplace? Where's your home? Let's try to identify and give you contact information for those emergency daycares that have been given the approval by the state to stay open, free of charge for you. And let me do the work because you have to take care of a baby that's about to turn 1 and you're just recovering from this illness. I think when we look at the questions about schools and reopening, on our team, we again just have to follow the guidelines by, you know, the Department of Public Health, by the state, and just make sure that until there's, again, a full reopening of the economy, as this is in a phased approach, we step in to fill in any holes or gaps that are existing. It's case by case. It'll come to us, but when it comes to, you know, phase 2, when they open hair salons, etc., we don't have the answer, but we will help support you until there is, you know, clear understanding of what this new normal will be for all of us. That's just my 2 cents.
Yeah, I would agree. I mean, I have a sister who's a primary school teacher, come from a long line of teachers. I just think we need to protect teachers, we need to protect children, but we also need to provide families, particularly the poorest, you know, the means to go back to work when they're able. So there's so many complex questions, and we're of course very worried, and we want to make sure that the poorest communities get the most support, because all of these practices like homeschooling, somebody mentioned, are incredibly regressive. I mean, it's no problem for my kid to homeschool, right? We've got internet, multiple computers, you know, it's no problem for me to work from this lovely place, but that's not true. And how we're going to assure the social and educational opportunities for children, which are already deeply unequal, is certainly on our minds as we think about what might need to be another surge or a more focused effort. Our own Mercedes Aguaber is asking about linkages to mental health, formal mental health, and also a more technical question, and a couple people have asked about Mexico. We, Partners in Health does work in the state of Chiapas, and we are doing some COVID work there. And Mercedes asked, and this might be a question for you, Emily, or John, whoever wants to take it, about connection with mental health services, and then also the use of antibody tests. She noticed antibody tests are on the Massachusetts dashboard, and what do we make of those?
And you take the mental health connection piece.
Yeah, definitely. And I might actually throw this to Didi and Shada as well, who are part of, in the presentation we showed the working groups that we have. And one of the working groups is specifically looking at mental health and connecting people with mental illness with much needed services. So that group's done a lot of work on how can the CRCs and the contact tracers and case investigators support people on the phone identify acute crises and kind of what needs to, what the kind of pathways are from there, depending on what's happening. And so those are some kind of general comments from me on that. And I'd love those guys who've been part of that working group to chip in on the specifics. And then there's also been some investment by the state on a hotline that's getting up and going. So that was on the mental health piece. I totally just spaced the other question.
The antibody test.
Oh, Shada, do you want to
comment? How is that being used in math?
I can tell you from the contact tracing world, we're not recommending or sending anybody from antibody testing. That doesn't mean I don't think there might be a role for that more in sort of a surveillance type way down the line. But what we're really doing and recommending from contact tracing is checking if people have COVID-19 who've been exposed to it, and that's all the PCR testing. So we're not sending anybody for antibody testing from the CTC. I don't know, Shada, do you want to add? Sorry, Dee Dee, I forgot your microphone isn't working. But Shada, do you want to add anything on the mental health care pathways, or Oscar, if you have specifics and the antibody testing?
Sure, I'll do my best. As far as the antibody testing goes, I think that there's still a lot of the medical community about what is the best role for antibody testing. Right now, for diagnosis, we're still using kind of PCR-based methods and gene expert type methods as the primary testing modality for diagnosing acute infection. As far as the mental health pathways, the Mental Health Working Group has done a lot of work on a few different aspects. One of the needs that many of the contact tracers, case investigators, and CRCs identified early on was for supports around people experiencing acute grief. As we discussed, this epidemic has really torn through communities and torn through families. And so the Mental Health Working Group did a lot around identifying resources for support groups, counseling, and other things to help people navigate the grief that they were experiencing. And to a lot of the points Oscar was talking about earlier, finding resources that were available in multiple languages and support groups that were available that really matched the needs of the communities that we were trying to serve. The Mental Health Working Group has also done work around trying to link people with more severe mental health illnesses, either experiencing depression crises, or we heard the case earlier with somebody with schizophrenia, linking those individuals to services as well, kind of similar to the way we've tried to link individuals with medical needs to urgent care or to ongoing primary care.
So, guys, I want to just jump in here because I think we have a few minutes left for the discussion, and I can see more questions coming up, which means people are really interested. But I also acknowledge that we have another session coming up for next week. And I would like to also acknowledge that, for some participants, it's late. So we don't have to spend the whole hour on the office hours. So it is optional. I probably can, ask one question, and it will be really an opportunity for our discussant and our professors to say something as we wrap up this session. So my question is really looking at the success I see from Massachusetts, really applicable on global scale. My question is, what do you consider as invisible drivers of your success? And what I see here, you discuss more, I think I see more visible drivers, like having contact tracers, having care coordinators, having, these systems, really establishing these systems. What else? What else would you want to say that is behind the success that you are having here, Emily, John, and everyone here? What can you say in terms of are there invisible drivers that people should consider as they design and implement these programs? And as we wrap up again, it would be really helpful to hear from you. What is the message would you give to anyone who is still here? I see almost 300 participants who stayed for office hours. What else do you want to tell as a message, a take-home message as you wrap up? So maybe each one of you guys could have, talk through those 2 points. Then we will wrap up the session and get ready for the next one. Maybe we can start with, I will go start with Oscar. So if you want to start, Oscar, that would be great.
Absolutely. So I think, talk about the way you mentioned systems and developing systems. when I first got to know PIH personally, when I was, again, in the Dominican Republic visiting family in Santo Domingo, when on the island, the Haiti earthquake hit. And suddenly the airports were down, the ports were down, and there was desperate need to get emergency supplies to Haiti as soon as possible. So at that point, PIH also had a collaborative program that they set up, a new system to have via the Dominican Republic local procurement of medicines and aid, food, water, fuel to Haiti and their network of clinics in Conge and in the Central Plateau. That same system was used to create the training hospital in Mirebalais that was in our readings. That is now one of the reasons why Haiti has been more prepared for 10 years later, an unprecedented pandemic. So when I think about our experience now in Massachusetts, where I grew up, I'm looking at how the care resource coordinators are looking at their own expertise, building off of partnerships with community health centers and other again, community groups to, again, have this new resource list. So if again, there's another wave, we're more ready, or our lessons learned in this messy process can be applied to other states, other programs that are looking at building their own contact tracing across the public sector, and civil society. That's my view.
Agreed.
Thank you, Oscar. So I would go to John next.
Sure. I mean, I think the thing that I would say is start, right? Just start. And begin now and like Emily said, we learned from our resource coordinators, right? So we started rolling out this program and started to attempt to understand what resources exist, what don't exist, how we can fill those gaps, and always founding everything that we're doing on the fact that this is an attempt to care for people, right? Contact tracing is not data collection and phone calls. Contact tracing is another opportunity to care for people. And I think for me, that's what I would say. Begin. Don't be afraid to start.
Very important, John. I think you mentioned sort of the community voices that really could be really important, invisible driver of the success. So, Shayla, do you want to go next?
Sure, and apologies, I keep turning off my video. My internet has been causing some issues, I think.
Yeah.
I think the key message that I would give, I'd give two actually. One is for those months is not just the medications you give or the IV fluids that you give or the tests that you run, but it is dealing with every aspect of what a patient needs and what a community needs. And that doing one without the other will not be successful. And we've seen that in the patients who come in and in the ways that this disease affects households and families. And then I think the other message that I would give is just that we are doing a lot right now for the short term, in the sense that we have an acute crisis in front of us that we as a global community are trying to respond to. But it is so important to gave the example of Mirebalais, where I had the privilege to work for a number of years, and nothing brings tears to my eyes more or makes me prouder than watching people who I had the privilege to call colleagues respond to this disease in ways that 10 years ago would have been unthinkable. And so while we're dealing with the short term and we're dealing with that all over the world, we should not forget the long term and how we can build systems that will last.
Yeah, that's great. Emily, please.
Yeah, I think that there's a lot of ingredients that are required and that we're lucky to have here in Massachusetts. And when I was trying to think about this, it all kind of comes down to people. And I think for one, that there's real leadership and vision here, and that we are lucky it's coming from the state government. And so that there's just been this courageous commitment to do what needs to be done. I think that has been a really important piece of that leadership, and to include in that the focus on equity. So I think that's a really big part of it. And then the other people are all of the people, so many people who have worked so hard on this and done it in a spirit of hope and optimism, even though we just had to start, like John said. And so embracing that complexity, embracing the fact that we're just going to learn as we go, and we're just going to go for it. And I think that that people with hope and optimism is really like a big ingredient, from the staff on the front lines on the phone to our government partners, to people staying up all night writing trainings and this and that, and people speaking to 351 local boards of health on the phone all week long at all hours of the day. So that's my answer, Manzi. Thanks.
Oh, that's great. Thank you. There's so many other questions that were answered, and obviously we would try our best to head back to you with the answers. But it would be really good, as Joya, as we wrap up, if you could make any comment to questions asked, but also highlight some of these invisible drivers, and if there's also anything else, any key take-home message that you would have to the audience, people who stayed for office hours, 300 people online. Please go ahead, please.
Yeah, so first of all, our great colleague Bea, I want to thank Bea and Amy, Hannah, Manzi, Phaedra, all of the people behind the scenes and in front of the scenes who've really put these great courses together. And we're so excited to be with so many of you. And Bea has been reminding us throughout, make no mistake, this is working. It's working in Massachusetts. Massachusetts has driven the R0 down. It is very hard to tease out what the attribution, how much is CRC, how much is contact tracing, how much is a mask order, how much is the social distancing. But we know that the combination of these things is what helps us stop epidemics. So make no mistake, Massachusetts is in a far better situation than almost any state in the country. And we're the only state that's brought contact tracing to scale with the resource care coordination function, and have an 85 to 90% pickup rate on phone calls. So no matter what critiques are coming in, this is working from the standpoint of infection control and equity. And I think that's a very, very important message. And so what I would say, and as we get the R0 down, you can take lots of different courses of this online. We haven't talked about the epidemiology as much as the how-to, because that's what we do, is delivery. But the R0 is down, it's less than 1. And that allows us to even think about reopening schools. But that's, of course, another, and maybe we'll have another course on that as we deal with this globally in the fall. But I think the goal of this 4-part webinar, the goal of Partners in Health, the goal of UGHE is to make the invisible driver and the most important driver visible, and that's inequity. And so when we think of the epidemic, we think, everything you see with COVID has that little weird electromicrograph with the spikes. And is that visible? Like, no. It's really the most important invisible driver of the epidemic is inequity, and we can see it all around us. It's much easier to see inequity. You walk downtown Boston and you see people living unhoused in the richest nation on earth and one of the richest states in the richest nation on earth. You see people who are living at the very margins of society getting evicted from their homes. So this is a visible driver, but it is invisible politically. And our goal with all of you around the world is to make inequity the visible thing that we address, to address healthcare, to address the pandemic. And if we hold ourselves accountable to addressing inequity, then everything will get better. Right? That is the key to a fair and more just. And this, in my view, is always going to be about political choice. We have the largest military budget in the world by far and the worst pandemic response. These are linked. These are not separate entities. This is about a set of political choices we make as a society. So we really appreciate all of you tuning in and getting to know you all over time and face to face when this is all over. But thank you all so much. And I hope you'll join us on Tuesday. We've got some amazing speakers. Dr. Camara Jones, who's a global expert and is certainly an American expert and institution on anti-racism work. She's a professor at Morehouse College, the previous head of the American Public Health Association. She will be joined by our colleagues in Navajo, who are talking about the terrible ravages of COVID in Indian country. And it will be moderated by Kate Oswald, who is our Chief of Policy and Partnership. So many of you ask questions about how do we take this and make it into policy? And Kate and Sonia and Camara will be able to really help take those questions further. So thank you all so much. And I was using my right hand.
Thank you, Joya. This is really powerful, and thank you everyone for joining the course. Please make sure you have your pre-readings online before the next session. If you did not have a chance to attend the first session, you can always watch the video, and we will consider that as that will count for your certification. So thank you so much all, and we wish you a good evening or good day. So we see you next week.
Bye everyone. Great job, everybody.